Good evening, everyone, and thank you for coming this evening. My name is Rags DeVleur. I'm with the Sunnybrook Board of Directors, and it's my pleasure to welcome you this evening to our second speaker series of the fall session. We're so grateful for the public support the speaker series receives. These lectures are a wonderful way to engage you.
We start the evening for once with good volume. At the beginning.
Oh, you can't hear?
And I've got thank yous all around.
Should I start over? Okay. Can you hear me now better? Okay. Good evening, everyone.
Good evening.
Is that better? I'm Rags DeVleur. I'm with the Sunnybrook Board of Directors, and it's my pleasure to welcome you this evening to our second speaker series of the fall season. We're so grateful for the public support the speaker series receives. These lectures are a wonderful way to engage you, our patients and community, in relevant and timely health issues. I can see by all of you attending tonight that diabetes is an issue that affects so many. The focus tonight will be on type 2 diabetes, which is by far the most common. Type 2 diabetes usually develops in adulthood, although a growing number of children in high-risk populations are now being diagnosed. Tonight, you will hear from several Sunnybrook experts who will discuss the role of diet and nutrition, medication, and mindfulness in managing diabetes in your day-to-day life. The support of a good healthcare team and the most reliable information are all critical steps towards achieving the very best outcomes and quality of life. So now, to begin, I would like to introduce tonight's moderator, Lee Kaplan. Lee is a diabetes nurse educator in Sunnybrook's academic family health team, which provides a broad range of primary care services to patients and families across the lifespan. Lee has a passion for providing quality, evidence-based diabetes education and support for patients with diabetes, as well as teaching and mentoring new practitioners in the field. Please join me in welcoming Lee to the podium.
Hi, everybody. Thank you, Rags. It's wonderful to have all of you here this evening. Welcome. Tonight, our event is called Enhancing Your Diabetes Management. We hope tonight's presentation will provide you or your loved ones with guidance on how to better manage your type 2 diabetes. We have a wonderful lineup of speakers and topics. Tonight, Jill Zwag will provide you with some nutritional guidance by dissecting the food rainbow. Dr. Jeremy Gilbert will discuss the latest information around medication use. And then Mona Hewes will provide a presentation on the benefits of mindfulness. We'll set aside some time at the end of the evening for you to ask our panel speakers some questions. For the question and answer session, we have placed small white blank cards on each chair. Please write your questions on the card, and between each speaker, our volunteers will collect them from you. Feel free to get up if you need to during the evening. We will not be having a formal break. The washrooms are located just outside the auditorium, and there are refreshments located in the foyer. I'd like to welcome our first speaker, Jill Zwag, who is a registered dietitian and certified diabetes educator. She has been working in the field of diabetes for over 27 years. She's currently working in the Sunnybrook Academic Family Health Team. Jill enjoys working with clients to help them living with diabetes easier. She also works with medical residents and nutrition students to educate about the challenges of making behavior change. Outside of work, Jill enjoys spending time with her family. Please welcome Jill to the podium to discuss dissecting the food rainbow.
Yeah, but I gotta get that. Where's the note? There it is. Welcome, everybody. Volume okay? Yes. Great. Tonight's presentation is going to take a closer look at improving the dietary quality of the foods that we eat by looking at benefits of eating different colored foods. So by the end of the evening, you will be able to list the benefits of eating 2 different colored fruits and vegetables, name 2 quality starch foods that are white in color, and list 2 sources of healthy fats using colors. Eating a variety of foods from all of the food groups provides the body with energy, essential nutrients, vitamins, minerals, and fiber. Some vitamins and minerals are essential nutrients that must be supplied through food. There are also other components in food, such as phytochemicals, which are not considered essential, but they do help the body function more efficiently and effectively. Let's look at each food group, find ways to include a variety of colors, and improve the quality of all the foods that you choose to eat. I'm going to start this evening by asking some questions or taking a quiz. The idea of these questions are to get you thinking about your own eating habits. Do you eat 2 servings of different colored fruits daily? You could raise your hands. Do you eat 2 servings of different colored raw vegetables daily? Do you eat 2 servings of different colored cooked vegetables daily? Do you eat white meats, such as chicken or turkey, more often than red meat? Do you eat fish weekly, or more specifically, different colored fish, like white fish, tilapia, sole, and red or pink fish, such as salmon or rainbow trout? Do you eat those weekly? So quite a few people are raising their hands, but let's continue on. Throughout my talk this evening, I want you to start to think about and identify areas in your own diet where you may be able to make some small changes. So even if you're doing all those things, we may be able to bump it up a notch. Food is made up of macronutrients and micronutrients. The macronutrients are carbohydrates, proteins, and fats. These are the main building blocks of food, and almost everything we eat must fit into these food categories. The body needs macronutrients in order to function. Carbohydrates are used as the body's main source of fuel, especially for the brain, kidneys, heart, and muscles. Proteins are used to repair new tissue and grow new tissue and regulate and maintain body function. Enzymes used for digestion and body immunity are made of proteins. Fats are necessary for survival. Cellular membranes are made from fats. And fats are required for the absorption of fat-soluble vitamins, such as A, D, E, and K. Within the macronutrient food group, there are also micronutrients. Micronutrients provide the body with essential nutrients in the form of vitamins and minerals, and non-essential nutrients in the form of something called phytochemicals, which we'll look at tonight. Vitamins and minerals are essential nutrients because they are needed by the body in small amounts to keep you healthy. Essential vitamins and minerals cannot be made by your body. They must be attained through food or supplements. The essential vitamins that the body needs are A, C, D, E, K, and there's a variety of B vitamins. Essential minerals are calcium, iron, magnesium, potassium, phosphorus, zinc, and sodium. Most people can meet their vitamin and mineral needs by eating a variety of foods from all 5 food groups. That's vegetables and fruits, grains and starches, milk and alternates, meat and alternates, and fats and oils. Eating balanced meals, moderate or controlled portions spread out over the day will provide your body with both the macronutrients and micronutrients that are needed to best function. The Clinical Practice Guidelines for the Management of Diabetes acknowledges that nutrition therapy and counseling are an important part of the treatment and self-management of diabetes. It's well documented that nutrition therapy can improve glycemic control. Frequent follow-up by a registered dietitian has been associated with dietary adherence, especially in type 2 diabetes. The plate method, or space on your plate, as seen in this slide, is often used to show a balanced diet. But it needs to be much more than just the food on your plate. The quality of each food group from a micronutrient perspective is important to consider. Have you thought about how to make your food choices better? How much color is on your plate? How can you use the rainbow to improve the quality of the foods that you eat? By choosing foods that are nutrient dense, you're going to get the health benefits far beyond just diabetes management. Phytochemicals are naturally occurring compounds. The word phyto means plant in Greek. Phytochemicals can be defined as various biologically active compounds found in plants, meaning they are everything the plant has that you want for your body. It is the phytochemicals that are thought to be beneficial in offering protection against type 2 diabetes, cardiovascular disease, and cancer. Phytochemicals are part of a large group of chemical compounds that are responsible for the color, flavor, and odor of many foods. Phytochemicals are thought to work along with vitamins, minerals, and fiber to promote good health and lower disease risk. Research strongly suggests that eating foods rich in phytochemicals provides health benefits. We know that a diet rich in fruits and vegetables is good for your health. We don't know how much of the benefit is due to phytochemicals themselves or the combination of phytochemicals, vitamins, minerals, and fiber. There is not enough research currently available to make specific recommendations on the amounts of phytochemicals. Thousands of phytochemicals have been identified, and research speculates that there are many more undiscovered in the foods that we eat. There are different groups of phytochemicals, and they're classified based on their chemical structure and functional properties. Each individual compound may have different health effects. Some of the best-known phytochemicals include carotenoids, such as lycopene, lutein, alpha, and beta-carotene, flavonoids, and anthocyanins. These phytochemicals mostly come from plants, fruits, and vegetables. Other phytochemicals found in whole grains, nuts, and seeds, such as lignans and phytosterols, can be found in the starch group. People who eat the recommended servings of fruits and vegetables have a higher intake of phytochemicals, which has been associated with a lower risk for chronic diseases such as diabetes and heart disease. Each food group can be dissected based on colors in the rainbow: violet, indigo, blue, green, yellow, orange, and red. Let's start at the top with vegetables, work our way through macronutrients, micronutrients, and colors. What is your favorite color? And do you eat foods that color? When thinking about space on your plate, vegetables represent half the plate. Loading up on vegetables is beneficial because they're low in energy density, meaning they're low in calories, and can be eaten in large amounts with little or no effect on weight and blood sugar levels. They are full of healthy nutrients. They're full of those micronutrients. They're low in fat, they're low in sodium, they're a great source of fiber, and most vegetables are something called low glycemic index. Low glycemic index foods break down to glucose in the bloodstream slower helping to control a slower rise in blood glucose levels. Choosing low glycemic index foods has been shown to have health benefits associated with helping to manage blood sugar levels in diabetes. Vegetables are also an excellent source of fiber. Fiber also helps to slow down the absorption of carbohydrates. Fiber has also been shown in research to help with reducing cholesterol in the blood, which can benefit your heart health. Fiber can also help keep you feeling full and create that feeling of fullness so you don't eat as much. Phytochemicals, though, is where vegetables get much of their color from. Fruits. Fruits are also full of vitamins and minerals, as well as phytochemicals. Eating fruits provides health benefits. People who eat more fruits and vegetables as part of an overall healthy diet are likely to have reduced risk of chronic disease. Fruits provide nutrients vital for health and maintenance of the body. Most fruits are naturally low in fat, sodium, and calories. Fruits are a great source of essential nutrients that are often underconsumed, such as potassium, vitamin C, and folate. They're also a great source of fiber. Just like vegetables, fruit gets much of their color from phytochemicals. Here are some studies that specifically look at the benefits of phytochemicals in fruits and vegetables. And I know the dates on these are a little older, but they specifically looked at phytochemicals. The newer studies weren't as specific. In 2000, they look at fruits and vegetables, but not the phytochemicals. So in 2003, a study in the American Journal of Clinical Nutrition found that it's not just the phytochemicals on their own that actually have the health benefits, but the complex mixture of vitamins, minerals, and phytochemicals in the whole food that are responsible for the antioxidant benefits. Another study in the Journal of Nutrition in 2006 found that increasing fruits and vegetable consumption from fewer than 3 servings to more than 5 servings per day was associated with a 17% reduction in the risk of coronary heart disease. And coronary heart disease could also be further decreased by 4% by adding another additional portion of fruit and vegetable per day to the diet. So what does Greene do for you? The natural plant pigment chlorophyll colors fruits and vegetables green. Dark green vegetables are an important source of folate, and folate is necessary for DNA duplication and repair. Folate has a high content of antioxidants. They also contain high levels of iron, magnesium, potassium, calcium, vitamin A, C, and K. Vitamin K is essential for blood clot formation. Here on the slide are examples of green fruits and vegetables. While phytochemicals are found in plants, antioxidants can be found in both plant and animal foods. So what are antioxidants? By definition, they are substances that help fight the harmful effects of unstable molecules in your body called free radicals. Antioxidants can help prevent damage to cells from these free radicals. In some cases, phytochemicals produce antioxidant effects. Back to our colors. What do orange and red do for you? Orange and red vegetables and fruit are rich in beta-carotene, which is converted to vitamin A in the body. Vitamin A is often referred to as the vision vitamin, as it helps with normal vision and keeps your eyes, skin, and immune system healthy. Many orange and red vegetables are also a great source of vitamin C, which is important for growth and repair of bones, teeth, and skin. Vitamin C also helps with iron absorption. Red vegetables and fruits are a great source of lycopene, which, as we learned earlier, has antioxidant properties. On this slide, you can see examples of both orange and red fruits and vegetables. What does purple do for you? Blue and purple vegetables contain phytochemicals in the anthocyanin group. This is what gives their food their intense color. Anthocyanins belong to a parent group called flavonoids, which also have an antioxidant role. Here are some of the commonly eaten blue and purple fruits and vegetables. Just as I was talking about the phytochemical anthocyanins, there was some research done, more current, in 2013, and this research was titled, "The Case of Anthocyanin Consumption to Promote Human Health, a Review." This study specifically looked at the benefits of anthocyanins. In this study, anthocyanins were found to have an anti-diabetic, cardioprotective, anti-inflammatory, and anti-carcinogenic properties. The study found that these actions were likely enhanced with the presence of the other vitamins and minerals within the colorful fruits and vegetables. The diabetes protection was associated with a decreased accumulation of adipose or fat tissue. Less adipose tissue helps prevent obesity and diabetes by reducing insulin resistance. I was in a terrible accident on my way to work. My diet crashed into a box of donuts. Well, let's move on to the next food group. Not quite donuts, but starches and grains. This group should only take up a quarter of your plate. No color? No problem when it comes to starches and grains, and they're in their more natural form. Some phytochemicals are colorless. The largest class of phytochemicals that are colorless is called flavonoids. Flavonoids have powerful antioxidant properties. Whole grains such as brown rice, quinoa, barley are rich in flavonoids. Whole grains are most nutrient dense when eaten in their more natural form, compared to more processed starches such as white bread, white rice, pasta, crackers, cookies, donuts. Processed starches have lost the nutritional quality that the phytochemicals have during the processing. On top of choosing more whole grains, let's look at other ways we can incorporate color to make starches more nutritionally dense. That would help improve the overall quality of this food group. Corn. Corn is bright yellow, and it's actually a whole grain. Beans and lentils are not whole grain, but they have a similar structure and thus health benefits. They're very high in fiber and provide nutrition density to the diet. These foods are excellent quality carbohydrates. They contain some plant-based protein and are a great source of fiber. As you can see on the slide, beans and lentils can definitely contribute color. There are green and red lentils, red kidney beans, and white navy beans. Both whole grains and beans and lentils are low glycemic index foods. Thus, they are digested slower, contributing to a slower rise in blood glucose levels. Sweet potato has lots of color, orange. They're an excellent source of vitamin A in the form of beta-carotene. They're also a very good source of vitamin C, manganese, copper, and some B vitamins. But how can it be whole if the wheat has been ground into a powder? That's a very good question. Be careful with more processed foods that use whole grains. Corn in corn tortillas, quinoa in granola bars, brown rice in pasta, and oats in cookies. The take-home message is that these foods, although they started out nutritionally good quality carbohydrate sources, they've been turned into more processed foods where the phytochemical benefits have been lost. In order to complete a balanced diet, let's look at the other macronutrient food groups, proteins and fats. Protein is found throughout the body. For example, it's found in muscle, bones, skin, and hair. It makes up enzymes and hemoglobin that delivers oxygen in your blood. Although proteins may not directly affect blood glucose levels, they are an important part of overall health. In the protein food group, you can get color from eggs, fish, and meats. It's pretty confusing lately as to what proteins are the best to eat. The Mediterranean diet encourages people to replace red meat with white meats more often. The Heart and Stroke Foundation encourages people to replace saturated fat with unsaturated fats more often. That would be replacing some of your animal fats with healthier vegetable or plant-based oils. And the DASH diet encourages no more than 6 ounces of lean protein per day. We also know that fish is an excellent source of protein. It contains omega-3 fatty acids that have been shown to have excellent cardiovascular benefits. You can benefit by choosing meat alternatives such as beans and lentils or tofu in order to gain the benefits of phytochemicals from your protein foods. In summary, variety is important when it comes to eating different proteins, as it gives you an opportunity to get different nutrients from all different sources. Healthy fats come from plant-based products, which contain phytochemicals as well as essential fatty acids, vitamins, and minerals. Making quality food choices in the fats and oils department includes healthy fats, which have some color. Think about healthy fats and where they come from. Plants. Avocado comes from a plant, and it's nice and bright green. Nuts and seeds can be different colors, from white to green. And I always think of oils, think about the plant and where they come from. The plants, like these sunflowers, can provide also lots of color. Choosing healthy fats, oils, and protein foods can help with satiety, as well as adding flavor and texture to your food. Now that we've dissected the food rainbow, how do we pull it all together to create healthy eating? If we go back to the questions asked at the beginning of my talk, it may help guide you to creating meals or planning for a week. So, let's ask ourselves again. Include 2 different colored fruits daily. For example, berries, red and blue, raspberries and blueberries, with oatmeal, a whole grain, or Greek yogurt, which has some extra protein in it, at breakfast. Choose an apple, red or green, for a snack sometime during the day. Include 2 different colored raw vegetables. Pack some carrot and celery sticks with a turkey wrap for lunch. Add some avocado and tomato to your wrap for more color. Include 2 colored cooked vegetables per day. Roast up some asparagus and grill some eggplant with your dinner. Add a piece of grilled salmon, there's that colored fish, and include a scoop of quinoa. You can certainly add some color to the quinoa as well, and quinoa is a whole grain. Include fish, poultry, and meat alternatives such as tofu, beans, and lentils more often than red meat. Add a salad with chickpeas and a grilled chicken makes a great meal. Add a colorful fruit to that if you like. Grab a handful of nuts and seeds for a healthy snack. A balanced diet is associated with good health and prosperity. On your chairs tonight, you received some recipe ideas that incorporate colors of the rainbow. You also have a blank grocery list. It's a little different than my list, but it wouldn't fit on the computer. Use this grocery list to help you plan your next trip to the store. What new colors can you add on your grocery list, and what new foods can you try? So instead of this, my doctor told me to eat more greens, so I went on a diet. Create this, a beautiful rainbow. Thank you.
Thanks, Jill, for allowing us to understand more about the food rainbow. Just a reminder, if you have any questions, please write them down on the blank white cards and raise your hand, and one of our volunteers will come by to collect them from you. I now would like to introduce our next speaker, Dr. Jeremy Gilbert. who comes with a wealth of knowledge and people love to hear him talk, and we're so glad to have him. He did his medical training at U of T, all of it, internal medicine, medical school, endocrinology residency. He's an active member in the Division of Endocrinology at Sunnybrook Health Sciences Center and assistant professor at the University of Toronto. He's the program director of endocrinology at University of Toronto. He's a member on the steering committee for the 2018 Diabetes Canada guidelines. So it's timely having him here. The national consultant editor at the Canadian Journal of Diabetes. Jeremy shows great enthusiasm, as I'm sure you will see tonight, for teaching. He completed his master's program at University of Toronto. An area of academic interest is teaching undergrads, postgrads, and continuing medical education in endocrinology and metabolism. He's a faculty advisor for residents, council for the Canadian Society of Endocrinology and Metabolism. He also, I can name them, but there's such a big list here of awards that Jeremy Gilbert has gotten for teaching. And now I'd like to invite Jeremy Gilbert to the podium to give his presentation on medication update.
Okay, so the first thing is we have to make sure that you can hear me, right? Is that the most important thing about the talk? Is you can't hear me, right? I'm too tall, or the podium's too short. That's the question, right? Okay, so we're going to put in the hearing aids. Okay, let's see if this thing here. Okay, I'll put this around like this. Okay, and now you can hear me, right? See how smart this guy is? Thank you very much. Excellent. Okay, I'm going to try and put this down like that. So this is a hard act to follow because Jill did such an amazing job. The medications do not cover the span of the rainbow. Okay, they tend to be white, and they're different shapes, but we'll do our the best we can. The labels are different. And they come to me, you know, you all come to me and you say to me, you know, I'm on the little white pill. I take a few of those and one of the reds and a few of the brown. Maybe it's a little bit of the colors of the rainbow. It's okay. Okay, so we're going to talk about some medication updates. Now, at first, I really want to acknowledge that many of you may have diabetes or know somebody who has diabetes, and I may not cover that particular medication this evening. It's impossible to really cover all of this in one evening. But I look forward to your questions, and if you have something that you want to ask, then we can have it more as part of our discussion together. These are my disclosures, which I put up there. As Lee mentioned, I do a lot of continuing medical education. A lot of industry sponsors those educational events, and so those are the disclosures as you can see there. But no honorarium for this particular presentation. It's my pleasure to give it to you. So for the objectives of this evening, I thought we would cover a few topics. One is talking about what's called clinical inertia. And that really refers to keeping the sugars above target way too long. We'll discuss a little bit more about what that means. We're going to talk about metformin, but really the big question is not about metformin, but what do we add after metformin? So we'll talk about that. We'll talk about how we divide different classes of medications of diabetes and end off with a little bit about insulin because there are some new insulins that are now available in Canada and Ontario. So to begin with, this is just looking at the prevalence of diabetes diagnosed by age and sex, and you can see in the females and males it's pretty similar. The prevalence starts to rise in about the 40s, 50s, and is highest in and around the age group of 70s. In Ontario, we have currently about 6% of the population with diabetes, probably closer truly to 9%. So somewhere between 6 to 9% of Ontario has diabetes. It's a very, very large population. Whenever people try and estimate how many people there will be in the world with diabetes, they always underestimate it. And we're looking at hundreds and hundreds of millions of people currently with diabetes across the world. So a major epidemic of sorts. I mentioned clinical inertia, and the concept here is that the Diabetes Canada guidelines encourages people to get their A1C into target, whatever that target may be, within 3 to 6 months. So you might come to your doctor and be told that your A1C is above target, And you say, okay, what can we do about that? So we work on lifestyle modification, healthy behaviors, diet, exercise. We may introduce medications. But the concept is that we're trying to get to target within 3 to 6 months. That's the goal. What's the problem if we delay that? So this is from the United Kingdom, data from the United Kingdom, and it looks at about 100,000 patients with newly diagnosed type 2 diabetes. And they said, we'll define treatment intensification, as being more aggressive with the treatment strategy, as adding one extra medication to a single medication. So let's say a person's on metformin, the A1C is above target, and they're going to add one more medication on top. And they're going to call a delay of more than 1 year as being a significant amount. They say that if you delay it by more than 1 year, that will increase your risk of MI, so you can see there, by 1.67, by stroke by 1.5, and by heart failure by 1.64. That means by saying, you know what, I don't want to take that extra medication here, that can lead to a higher risk of complications like heart attack and stroke and heart failure. So the guidelines recommend that we try and get to target within 3 to 6 months. Let's see how we're doing. And, you know, I hate to give a failing grade to Canada or to the US, but this is truly a worldwide problem. And specifically, I can say in my own practice in Ontario and what I've seen, this is a problem that exists. If you ask healthcare professionals what the target A1C is, they can tell you. But getting people to that target has been a challenge, that implementation. So we said that our goal is 3 to 6 months. Let's say the target A1C for a particular person is less than 7%. What's a reasonable time frame based upon the guidelines to say that it's okay? Would we say 3 to 6 months is perfect? Would you say 9 months is reasonable? 12 months? Okay, let's see. You can see on the y-axis, you can see on the cursor here, the time is actually not in months, but in years. This is already going to be a problem, as you can see. If it's going to be taking years to get into target, this is a problem. For people who have an A1C over 7%, somewhere between 7 and 7.5%, on average, it takes about 3 years before a doctor will add another medication to get the person into target, on average. Maybe that's because A1C isn't so bad. 7 to 7.5 isn't so bad. But let's say it's 7.5 to 8%. It takes an average of about 2 years. And even at its worst, of an A1C over 8%, it takes an average of 1.5 years. So if the guidelines are saying 3 to 6 months, where are we? We're not there. And I don't believe this is truly, honestly, anybody's specific fault. So we might say, well, it's the doctor's not offering it. Well, sometimes the doctor's offer it and the patients don't want to take extra pills. And sometimes it's because the doctors aren't thinking it's so bad and they say, you know what, it's not worth offering them further medication. We need to work together as a healthcare community to try and improve this particular problem. As to what the target should be, that varies. This is from the Diabetes Canada guidelines, and for most people, we do target an A1C less than 7%, but let's be honest, some people are frail, a little bit more, have issues with comorbidities and other medical problems where it might be unsafe to target such an aggressive target, and maybe we have a higher target of 7 to 8.5%. And sometimes we're even more comfortable to have a target less than 6.5%, depending upon the individual in front of us. So what this slide tells me is that first thing we need to do as a relationship together is we need to establish what the target is. Then our next step is to try and get to that target within a reasonable time frame. So how do we get to target? So lifestyle modification is key, and Jill gave us a very nice discussion about some dietary choices that can be good. We have had it at the speaker series also discussion regarding exercise as being useful. Clearly smoking cessation is important. Mona's going to talk to us about mindfulness. So there's a lot of healthy behaviors that are out there that can help improve it. And as a doctor, I don't believe medications are the answer, believe it or not, despite the topic I've been asked to speak about. But the rude truth is that these are actually cornerstones to the therapy. But when they don't work, then medications sometimes become necessary. And metformin is first line, and it's first line wherever you are in the entire world. Whether you're in Beverly Hills, California, or Sub-Saharan Africa, Asia, Europe, Canada, it doesn't matter. Metformin is first line. What is second line is debatable. And so, a complicated slide, but I wanted to quote it because it comes directly from Diabetes Canada. This is the algorithm that we're instructed to follow. So we begin with lifestyle modification, and then we look at the A1C. Is the A1C below 8.5% or above 8.5%? If below 8.5%, think about metformin and lifestyle modification. If over 8.5%, think about combination therapy earlier rather than later. And if they're still not at target, then try and match the patient and the agent the best way possible. In November 2016, this was updated based upon some trials that showed particular evidence and benefit in people who have had a heart attack, stroke, angioplasty, peripheral vascular disease. Those particular individuals actually benefit from certain medications. And so a priority needs to be given to an SGLT2 inhibitor with demonstrated cardiovascular outcome benefit in that context. If a person has not had a heart attack, stroke, or so forth, then we try and match the patient and the agent the best way we can. And what does that mean? Well, let's say a person is very overweight. We would try and select a medication that helps with weight loss, or that's weight neutral. Let's say somebody has an issue with dementia, where avoiding low blood sugars is of keen importance. In that context, we'll try and avoid a medication that leads to low blood sugars. Sometimes we're limited by kidney function in terms of which agents we choose. And so that may be a factor. We try and make the decision based upon the patient in front of us and the agents in front of us and try and make the best match possible. In recent times, since 2009, there have been a series of newspaper reports, media reports, journal articles about results from key landmark trials, cardiovascular outcome trials that have shown benefit and safety of certain diabetes agents. And so that has really changed how we practice medicine. And in a lot of times, we may recommend a particular medication for a particular individual for these reasons. Now, be aware that many medications need to be stopped if the kidneys are not working well. And sometimes a dose reduction is all that is needed. Sometimes it needs to be stopped completely. But often when we're doing blood work to check for cholesterol and sugars and blood pressure and so forth, and these are the factors we're monitoring, one of the things that we do look for is how the renal function is doing. And when we start a medication, the renal function may be at this point, but over time it may change. And therefore the medication may also need to change over time. A very complicated slide. Do not memorize it. But look at the rainbow. I'm doing well. Okay. We have some red, yellow, and green on this slide. Okay. So what is this? This slide is what I use to help select the appropriate medication based upon kidney function. And again, I'm not asking you to memorize this, but just to have in the back of your mind to know that depending upon how the kidney function is, certain medications are in red, they cannot be used. Certain medications are in green, permitted. And certain medications are in yellow, they have to be used with more caution or dose adjust or considerations thereof. And so this table, I encourage family doctors, other endocrinologists to have in their clinic space so that when they see a particular individual, they say, aha, your GFR is this today, you're on these particular medications at this time, these are the appropriate adjustments that need to be made accordingly. And this changes over time. Now, there are currently available certain medications called Dpp-4 inhibitors and GLP-1 analogs. These medications are commonly used after metformin. I put for you the names of the medications, the trade names, and the generic names so that they're easily available so you can see their names over here. And you may have seen some of these medications. You may know people who are on these medications. Maybe yourself is on one of these medications. And so here is a list of these medications, and I'm going to explain to you why they are sometimes selected. I should note that within these medications over here, we had talked about metformin being first line. They also often come together, the DPP-4 inhibitors, with metformin in a fixed dose combination. If you're on metformin at 500 milligrams pill, and you're on the full dose at 4 pills a day, and you add a DPP-4 inhibitor, that would be 5 pills to take. But if you use it as a fixed dose combination, you can reduce that down to 2 pills. And so that's less pill burden, better adherence, better results. And they're covered by ODB. So that's an advantage. And here are a list of the combination of metformin DPP-4 inhibitor tablets that come together, and you may recognize some of these names. I'll also point out the second one from the top is Janumet XR. You can see the frequency is OD, which means once per day, as opposed to all of the other ones, which are twice per day. And that also can be convenient for people who may miss an evening dose or forget to take it. Having it once a day makes it a little bit easier. So the DPP-4 inhibitors have the advantage of being an oral agent. It's not an injectable. It's covered by ODB. It's weight neutral. It doesn't cause low blood sugars, and is fairly well tolerated, minimum side effects. The disadvantage is it doesn't lower the A1C quite as powerfully as some other agents, and you don't really get good weight loss with this agent. It's more weight neutral. It's good that you don't get weight gain, but it's weight neutral. The GLP-1 receptor analogs, as we mentioned before, are quite effective in lowering sugars. They are quite powerful, and they have the added advantage of weight loss, not just weight neutrality. Still no low blood sugars. They do give some side effects of some GI upset, so like some nausea and so forth, but they tend to be temporary. So some side effects last as long as you take the medication. This only lasts for a few weeks and then tends to go away. Also, some recent studies have shown good benefit of these drugs on the heart and kidney, such as with Victoza in the LEADER trial. And conveniently, although they are an injectable, which you could argue is a disadvantage, they're very small, and sometimes you can even get away with giving it once a week, which isn't so bad. The disadvantage is that it is not covered. They are quite expensive, and it is an injection. The GI side effects are mentioned as before, but are temporary. Again, I'm happy to take questions at the end, and we can have further discussion about any of these agents. The other group that we commonly see now after metformin are the SGLT2 inhibitors. And they include 3 different medications that are available in Canada: Cana, Dapa, and EMPA, or Invokana, Forxiga, and Jardiance. Now, as full disclosure, I did not select any of the names of any of these medications. I know they're difficult to pronounce, they don't make any sense, but don't shoot the messenger. Just like before, I had showed you combinations that are available with metformin with the DPP-4 inhibitors, so too, the SGLT2 inhibitors are also available in fixed dose combination with metformin for better patient adherence and convenience. So I think that this is an advantage. Most of these are not covered by ODB, except for the top one, Zigduo, which is currently covered by ODB. So the concept of SGLT2 inhibitors are these drugs work on the kidney. We have a bunch of sugar that goes through our kidney every day, about 180 grams worth of sugar that goes through our kidney every day. And all of that sugar gets reabsorbed right back into our blood. And if you dip the urine, there should be no sugar in the urine in a healthy individual. All that sugar goes through the kidney, but none of it sees the urine because it gets reabsorbed. And all of that reabsorption is largely done by a transporter called SGLT2. So the idea is if you block that SGLT2, then the glucose, instead of getting reabsorbed back into the blood, all gets lost in the urine, and hence the glucose goes down. And with that, since we can't pee solid, little secret, you can't pee solid, water has to come too, and that will lower your blood pressure, and all that sugar coming out is going to lower your weight. So what you end up with is 1 pill once a day that lowers your sugar, lowers your blood pressure, lowers your weight, and cannot cause low blood sugars because it has nothing to do with insulin. And so that's an advantage as to why this class of medication has become popular. So you can see here the glucose is going through the kidney, and it's all getting reabsorbed back into the blood in the red. With SGLT2 inhibition, though, you can see all the glucose being lost in the urine here. So SGLT2 inhibitors work very well in terms of lowering A1C, which is very nice. They do lower the blood pressure, they do lower the weight, average of about 3 kilograms. And again, no hypoglycemia unless you're using it with other agents that can cause hypoglycemia. But they do have some caveats, as does everything. They are only good at lowering the sugar if the kidneys are working well. If the kidneys are not working well, and these drugs work on the kidneys, they are not going to be very effective in lowering the sugars. All that sugar going through the pelvic cavity and being pinged out can lead to higher rates of urinary tract infections or yeast infections. They tend not to reoccur, they tend to be easily treated, but it is a side effect that should be noted. Also, all that sugar and water coming out can lead people to get volume depleted. So it's very important to stay well hydrated on these medications. In one trial with one of these medications, there was actually reports of higher rates of fractures and amputations. We don't understand why that is necessarily at this time, and further studies need to be done to kind of verify this, but that has been a concern, and in particular, if a person has a history of amputation or bad peripheral vascular disease, we tend to be avoiding at least this particular drug of canagliflozin and maybe even the other SGLT2 inhibitors.
What is DKA?
You're right, I skipped a line. DKA, good eye. So DKA stands for diabetic ketoacidosis. And DKA is a hyperglycemic or high blood sugar emergency. Symptoms vary. They can feel nausea, vomiting, abdominal pain, short of breath. You really actually just feel lousy, truthfully. And the sugars are often quite elevated. These drugs, SGLT2 inhibitors, have been associated with higher rates of DKA. And sometimes the sugar isn't even that high with these agents because it's being lost in the urine. A healthy individual walking around taking an SGLT2 inhibitor will not go into DKA. However, if a precipitant is added, that can be a problem. Therefore, sick day management becomes very important. And so what happens there is if a person gets the flu or they get dehydrated and they're having pneumonia and they're volume depleted and they're not doing well, we ask them to hold that medication. Or if they're going for an elective surgery. And often when people come into hospital for various reasons, we hold this medication because of that reason. The SGLT2 inhibitors have been well studied in cardiovascular outcome trials. These include the EMPA-REG trial, published in September 2015, the CANVAS trial, released just in June this year, June 2017, at the American Diabetes Association in San Diego, and the DECLARE trial, which is going to be coming out in 2019. So there's a variety of trials that are available with SGLT2 inhibitors, that have been done and that are coming up. Just to point out a little bit of this evidence, this is with empagliflozin, the EMPA-REG trial mentioned in September 2015, which resulted in a change in our Diabetes Canada guidelines. You can see here that there was a reduction in the composite endpoint, total endpoint, of cardiovascular death, non-fatal MI, and non-fatal stroke. When you looked at all of that together, by adding this drug, there was a 14% significant reduction in those events, which is important since all those people who were in this trial had diabetes, and all of them had already underlying cardiovascular disease. These were a sick group of people, and we actually were able to reduce the events that they were going to have. In fact, the all-cause mortality, dying for any reason, with diabetes and having these things, if you added this drug, that was reduced by 32%. Pretty exciting, because we didn't have, prior to this, really any drugs that actually reduced mortality in diabetes. The CANVAS trial, which is with canagliflozin, replicated some of these results and also showed a 14% reduction in that composite endpoint. Another SGLT2 inhibitor, so really two showing that benefit in the primary outcome. However, this concern about amputation was noted. It seems, though, that the people who ran into this trouble of amputation with canagliflozin were people who already had a history of amputations. So that, to me, is where I'm making the decision of who I'm not going to offer this medication to. If somebody has a history of peripheral vascular disease or amputation, I don't want them to take this medication for that particular potential side effect. However, I would still use it in many other people because it's really good for the heart and good for the kidney and good for the sugars and blood pressure and weight. So I mentioned briefly sick day management in the context of the DKA that was mentioned. We have a list of medications that are in the diabetes guidelines that we recommend be held if an individual is sick. Now, the mnemonic stands for SAD meds. Okay, SAD meds, and they include sulfonylureas, ACE inhibitors, diuretics, metformin, ARBs, NSAIDs, and SGLT2 inhibitors. So that's the SAD meds. Now, you may be on certain medications, and you may not be sure if your medication is included in the SAD meds, because these are just group of medications. It is useful to talk to your healthcare provider or pharmacist, truthfully, about what medications you're on and what to do when you're sick. Just speaking as a doctor here, I think I'm pretty good at telling people why to take a particular medication. I'm not so bad at telling them what side effects may occur from that medication. Where I think we all need to improve upon is what to do if you're sick. Because if you're home alone on a Saturday night and get sick, you need help and you need to know what to do. And I think sick day management is something we can do better. So there actually is a tear-out sheet in the Diabetes Canada guidelines that we can give to individuals with diabetes to say what to do when you're sick to hold these particular medications. Let's conclude with insulin in the last 5 minutes or so. We're okay? 5 minutes? So we have a lot of new insulins that are available. Fiasp, the one at the top there, is a very rapid-acting mealtime insulin that has recently become available. And you can see here there's Humalog, NovaRapid, and Apidra as kind of faster-acting insulins, regular insulins that are a little bit longer-acting, NPH, which is a basal background insulin. There's Glargine, known as Lantus, and a biosimilar version of it called Basaglar. And then two newer insulins. So one newer insulin is Toujeo, which is a more concentrated version of Lantus. And there is Levemir as well, similar to Lantus. And actually just 2 weeks ago, a new insulin came out on the market in Canada called Degludec. So there's a lot of new insulins that are available. And the concept of using different insulins is to try and get the sugars as good as we can while minimizing low blood sugars and minimizing variable blood sugars, so that yo-yo up and down blood sugars. So I'm not going to go into the details of these slides, but I wanted to put it out there just to say that there is different costs to the different insulins, and that needs to be taken into account because obviously the cost of medications is so important. We appreciate that some insulins last for shorter periods of time, some last for longer periods of time, and they all have different rates and higher or lower risks of causing low blood sugars. And so if individuals are struggling with that, we try and use the insulin that helps reduce that the best we can. The newer insulin, as I mentioned before, Toujeo, has the advantage of being very long-acting and very smooth with less variability and less low blood sugars. It's a third the volume. So therefore, for people who are on higher doses, it's a little bit more comfortable. Basaglar is a very similar insulin to Lantus in every shape, in every way, except cheaper. So that's a nice advantage for some people where cost is a major issue. Tresiba is the one that came out 2 weeks ago, and it has a very long half-life. It's flexible, less low blood sugars, less variability, and comes in 2 different types of pens. There's pre-mixed insulins, that's the Novomix 30 or Humalog Mix 25 that we use. Disadvantage is it's not as flexible, so you have to be very regimented in diet and activity for it to work well. The rapid-acting insulins, as we mentioned before, exist, and Slightly different profiles in terms of how quickly they work and how long they work for. Common ones being Humalog, Novorapid, and Apidra. The Fiasp is that rapid-acting one that's come out. And for people who are in very large doses, the Humalog 200 can be used. So in summary, we talked about clinical inertia and how we need to recognize what the targets are for the sugars and then try and get to that target in a more speedy fashion. We talked about some different types of medications, Dpp-4 inhibitors, GLP-1 analogs, and SGLT2 inhibitors, some of their advantages and disadvantages, and how to select them based upon the Diabetes Canada guidelines. Finally, we discussed different types of insulins that are available, a brief review of the different ones, some newer ones that have come out recently, and why those ones may be advantageous as it relates to getting the A1C to target while reducing variability in sugars and low blood sugars. So with that, I will conclude, picture my family, and thank you all for attending. I'll be back for some questions later.
Thank you, Dr. Gilbert, for that colorful talk on updating our medications for diabetes, and hopefully we'll be able to take that new information back to our healthcare team to discuss if changes and what might help our management be better. Now I'd like to take the chance to introduce our final speaker, Mona Hewes. Mona is graduated from the Faculty of Nursing at the University of Toronto, has over 30 years experience in Canada and the US and working in a variety of healthcare settings, including public health, managing care, health promotion, community-based wellness centers, and health quality. As a certified diabetes educator, Mona provides individual counseling and group classes. Please welcome Mona to the podium to talk about the benefits of mindfulness.
You can just adjust that around your radio.
Did I put it the wrong way?
Yeah. If you put it on this, sorry, you had it right.
Yeah, okay. Yeah. Okay. I do. Yeah.
Okay. Thank you, Lee. I'd like to explore the topic of mindfulness with you. I realize, though, that we've been sitting for quite a while now, so it might be nice, if you'd like, to stand up for a moment and stretch. And while we're stretching, I'm just wondering how many of you actually have heard about mindfulness, or may perhaps already have a mindfulness practice yourself. So if you could raise your hand. Wow, that's great. That's great. Thank you. Please be seated. My main objectives today are to clarify what mindfulness is, how it may have some benefits for your overall wellness, and finally, to explore some simple ways that you may be able to incorporate mindfulness into your day-to-day life, if you so choose. To make this meaningful and practical, I will be inviting you to join in a brief mindfulness practice in just a little while. This gentleman is looking at the mall directory and reading, "You are here, but your mind is somewhere else." I wonder how many of us can relate to this. Well, the mind's natural tendency to wander has been studied by researchers at Harvard. The researchers found that 46.9% of our waking lives were actually thinking about something other than what we're currently doing. They also found that people felt happier if they were focused on what they were doing, even if what they were doing was unpleasant or neutral. If you'd like to learn more about this interesting study, simply Google "Wandering Mind is an Unhappy Mind," and you will view this fascinating 10-minute YouTube presentation by psychologist Matt Killingsworth. So we see that we are often not fully present in our moment-to-moment experiences and can actually go about our day on autopilot, mindlessly. This can impact our overall feelings of well-being and add to our stress or detract from our overall satisfaction with our lives. Add to that the burden of dealing with the daily demands of diabetes management, which can be so stressful and distressing. There's just so much to do. Exercising, making healthy eating choices, perhaps taking medications or monitoring blood sugars, going to medical appointments with Dr. Gilbert. All of this on top of an already very busy schedule. So mindfulness can be a valuable addition to our toolbox of coping strategies. It can enhance our ability to focus, help us become more aware of our needs and thoughts, and help us pause so we can respond more effectively to situations. You may have noticed that recently there's been a surge in interest about mindfulness. These are just a few of the magazines currently available. And this doesn't include all of the books, websites, and other resources that are very easily accessible. But what exactly is mindfulness? This definition is from Jon Kabat-Zinn, who is internationally known for his work as a scientist, writer, and meditation teacher engaged in bringing mindfulness into the mainstream of medicine and society. Kabat-Zinn defines mindfulness as paying attention in a particular way, on purpose, in the present moment, and non-judgmentally. The non-judgmental part of the definition refers to the idea that mindfulness involves acceptance. It's about being able to witness whatever comes up without condemning it or pursuing it. This kind of attention nurtures greater awareness, clarity, and acceptance of present moment reality. It wakes us up to the fact that our lives unfold only in moments. And if we are not fully present for many of those moments, we may miss what is most valuable in our lives. To Kabat-Zinn, mindfulness is simply the art of conscious living. It is simply a practical way to be in touch with the fullness of your being through a systematic process of self-observation, self-inquiry, and mindful action. The overall approach of mindfulness is gentle, appreciative, and nurturing. I think it's also important to clarify that mindfulness is not a relaxation exercise. Mindfulness is really about being present with what is here in this moment, whether it's pleasant, unpleasant, or neutral. Mindfulness is also not a quick fix, but rather a practice, an approach to life. And finally, mindfulness is not a religion, although the philosophy did derive from Buddhist tradition. Mindfulness-based stress reduction, or MBSR as it's often referred to, was started in 1979 in Boston by Jon Kabat-Zinn in a hospital setting. He worked with patients who were dealing with pain and chronic illness. This 8-session program combines mindfulness meditation and gentle yoga. It teaches participants to bring an interested, accepting, and non-judgmental attitude to all experiences, including difficult sensations, difficult emotions, thoughts, and behaviors. There are now over 750 MBSR programs worldwide in 80 countries. I know it says 720, but it's really more than that. MBSR has evolved into a practice that is being applied to a wide variety of health problems, as well as being used for general health and overall stress reduction. And it's the most researched meditation modality in the world. Research on the effectiveness of mindfulness has been done in a wide variety of settings. healthcare organizations, schools, the military, police force, and for a wide variety of conditions such as high blood pressure, depression, anxiety, chronic pain, migraines, fibromyalgia, and psoriasis, just to name a few. The research on the benefits of mindfulness can be summarized into a few main categories. Improvement in symptoms. The research is strong for the positive impact of mindfulness on stress reduction, emotion and attention regulation, reduced rumination, reducing mild to moderate depression and anxiety, and preventing depression relapse. Improvement in neuroplasticity. When we focus our attention on purpose, brain function and structure changes. A key study in 2011 showed that an 8-week MBSR program led to changes in brain regions that are associated with memory, emotional regulation, empathy, and self-control. Recent research has shown a link between mindfulness practice and the slowing down of cellular aging. With respect to diabetes and mindfulness, the evidence for benefits center on already proven effects on depression, anxiety, and stress. Studies looking specifically at people with diabetes have often either been too small or too short. Clearly, more research is needed in this field, and there's definitely interest. To explore further the concept of neuroplasticity, we can use the example of physical exercise. You know that if, for example, you want to strengthen your bicep muscles, you have to exercise them, perhaps doing bicep curls. You certainly don't expect that you will get stronger by just doing the exercises once. So you do the exercises week after week. You may not notice much improvement at first, but over time, your biceps do get stronger and bigger. The point is that it isn't enough to just understand that working your arms makes them stronger. You actually have to put in the time and do the work. It takes commitment. So what do you need to do if you want to feel more connected to yourself and to your life? Well, we know that through neuroplasticity, your mindfulness practice can actually change your brain. As the saying in neuroscience goes, neurons that fire together, wire together. So each time you notice your mind has wandered away and you come back to the present moment with kindness, you're actually doing a mindfulness repetition. This opens up the possibility of strengthening the feel-good circuitry in your brain, and this has a direct impact on your life. But again, it takes commitment and patience. So if I notice that my mind goes over here to my to-do list, and then it goes over there to, oh, what am I going to make for dinner? And then it goes over here somewhere else. Each time that I actually bring my mind back to the breath, that's another mindfulness repetition. That helps me to strengthen my mindfulness muscles, so to speak. So we've explored how mindfulness practice can be beneficial in a number of ways. Now let's look at how we can integrate mindfulness into our lives. First, let's discuss formal practice. This is when we plan time to focus on specific methods of cultivating mindfulness, such as sitting meditation, which involves sitting in a chair or on a cushion while cultivating awareness of breathing. Start with a short time, perhaps even 5 minutes, and just focus on the breath. We will be doing a breath awareness practice shortly, so you'll have a chance to try this one. Body scan is methodically paying attention to different parts of the body, from the feet right up to the facial muscles. This helps develop a mindful awareness of bodily sensations and can help relieve tension. Mindful movement includes walking meditation or gentle yoga, which is the practice of postures. Well, how about informal practice? These are opportunities available to us throughout our normal day-to-day activities where we can choose to be more mindful. For example, a helpful practice can be mindful eating. So when you're eating, you focus your attention on just that one activity and not doing anything else, not reading or watching TV or checking your email. You look at your plate and you notice the colors. You take in the aromas. You notice the textures of the foods you're eating. You savor each bite. You pause between bites. Use all your senses in choosing to eat food that is both satisfying to you as well as nourishing to your body. Be present for all your moments. Whether you're brushing your teeth, taking a shower, drinking your tea or coffee, walking to the bus, driving somewhere, listening to a friend, try to do it all mindfully. You can also consider taking a break from technology. Just turn off that phone or computer. And you can also cultivate mindfulness reminders. For example, if the phone rings, use the ring as a reminder to take a couple of deep breaths to help you to remain calm. And to smile, so when you answer the phone, you're in a friendly state of mind. Another way is to connect to your senses when you're experiencing something that you really want to remember, something precious. Take a moment to become aware of the colors, the sounds, the temperature, the smells, all of the details. Increasing your capacity for mindfulness supports many attitudes that contribute to a satisfied life. Being mindful makes it easier to savor the pleasures in life as they occur, helps you become more fully engaged in activities, and creates a greater capacity to deal with stressful events. By focusing on the here and now, many find that they are less likely to get caught up in worries about the future or regrets about the past. So now, why don't we give it a try? I'd like to invite you, if you wish, to experience a short mindfulness practice. For this short practice, we're going to focus on the breath. This is a classic foundation of meditation, as it's very portable. It's something you can do anywhere. Sitting comfortably in a dignified posture, allow the eyes to either open with the gaze unfocused in front of you or gently closed. Set the gentle but firm intention to be as awake as possible, to be as in touch as possible with the present moment, just as it is for you right now. Gradually allowing your attention to alight gently on the breath moving in and out of the body. Noticing where the breath sensations are most vivid for you right now. And without any forcing or striving whatsoever, just allowing the breath to be as it is, moment by moment, and breath by breath. Now, sooner or later, it's inevitable that we will notice that the mind has a life of its own, a very busy, active, inquisitive life. So even with the strongest of intentions to keep our attention on the breath and sustain it breath by breath, this intention may get sidetracked and our mind wanders, perhaps to the past or perhaps to the future. It could be anything. And the breath that we were paying attention to can disappear from our awareness. But in any moment that you notice this, not turning that into a problem, but rather simply and open-heartedly and affectionately noting what is on your mind in this moment, and then gently coming back to the breath. So when you're recognizing that the mind has drifted, wandered, that recognizing function is already back. That is awareness, awareness itself. We simply pick up on how the breath is in this moment. Resting here, fully awake, with no agenda other than to be awake. Allowing each breath to be utterly fresh. Letting go of the past, even the last breath. Letting go of the future, even the next breath. And simply being with this breath. And as the meditation comes to an end, you might give yourself credit for having spent this time nourishing yourself in a deep way by dwelling in this state of non-doing, in this state of being. And as you move back into the world, allowing the benefits of this practice to expand into every aspect of your life. When you're ready, please open your eyes. Now I'd like to invite you to please turn to a neighbor and let's just take 30 seconds each to share what it felt like to experience a few moments of mindfulness. I know that's a short time, but if you haven't switched, can you please switch so you both have an opportunity to share? Wonderful, thank you. It was great to hear that there was quite a bit of chatter going on, so I hope that that was a helpful opportunity to share what your experience was. So if you'd like to explore mindfulness further, there are many resources available. These are just some of the websites that can be helpful. And these are just some of the books that are available. Actually, John Kabat-Zinn's book, Full Catastrophe Living, is a really good place to start. It gives a very good foundation, and it's based on that program that we discussed earlier. In closing, I hope this brief introduction has helped you gain some understanding of what mindfulness is, how it may be beneficial, and has perhaps stimulated your interest in exploring some ways to cultivate mindfulness in your life. Thank you all for your attention. I think this one's, no, that one's not mine. That one's yours, yeah. Did you want this? Don't keep that one.
Hi, everyone. Thank you, Mona, for that living in the moment, being present. Heard a lot of chatter when you brought up the us trialing it, and that was quite lovely. And people were saying they felt more relaxed or right there, and I think that's an important piece when we look at enhancing our diabetes management. We will now begin our question and answer session. If you still have any questions to be collected, just a final call to please raise your hand and a volunteer will come by and collect it from you. Thanks. Yeah. Please come to the, no, I'm just gonna, yeah, we'll go one, we'll just rotate between, yeah. Because Mona hasn't gotten her questions yet, unless Mona can.
So what we'll just press the button. Okay, so what we're going to do now is we're going to take a few questions. This is probably the highlight of it, actually, because it allows for some interaction and some panel discussion. So feel free to stay, and we'll give it a bit of time, and then we'll get everybody home at a reasonable hour.
Yeah, so I'm just collecting Mona, so why don't you start, Dr. Gilbert, and then we'll move to Jill, and I'm just going to pass it over to her.
We're just going to take turns asking and answering questions. The first one I got is, what is the best way to measure progress in controlled type 2 diabetes? How often should this progress be measured? So the most useful test in assessing diabetes is the hemoglobin A1C, or the A1C. The disadvantage of it is it doesn't reflect the variability in the sugar. So a person can have lows and highs that may not be detected in the A1C itself, but the A1C is what likely leads to the most risk for complications as it relates to sugar control. So I would say the A1C is probably the best parameter to be used, and how often it should be measured really depends upon the stability of the individual. Someone's unstable, probably every 3 months should be measured. Because it reflects the average sugar over the past 3 months. Somebody who's more stable, 6 months, maybe even up to a year. That was my first question. You want to take a turn?
So one of the questions I got was, what is healthier, raw nuts or unsalted roasted nuts? And to be honest with you, they're both good. There's not a difference nutritionally. So certainly the sodium content of nuts, some people may want to be careful with, but this is unsalted. And then along the same question was, why are raw tomatoes less important than cooked? And again, both are good, and tomatoes are one of those red fruits or vegetables and contain lots of phytochemicals.
Okay, we're going to do some rapid fire. Okay, so next question is, what is the max metformin dose? Somebody said, their doctor said 5 pills a day. So metformin actually is generally, in most cases, 500 milligram dose per pill. And the benefit on A1C peaks at about 1,000 milligrams twice per day. So that's about 2,000 milligrams per day, or 4 tablets. So if you're on 5 tablets, there's unlikely to be much extra benefit on going from 4 to 5 tablets, and you may have a little bit more side effects. So in my own practice, I tend not to go anything more than 1,000 milligrams twice per day. One other question here was a question about prediabetes. So somebody who doesn't have type 2 diabetes, but in the prediabetes state, and the question was, not on any diabetes medications, a couple times in the morning, has some symptoms of low blood sugars, but they're okay when they check them around 4 or 5. And yeah, it's unlikely a person's going to experience true hypoglycemia unless they're on insulin or a sulfonylurea medication like glyburide or diamicon. So those symptoms are just probably a sense of feeling higher blood sugars and then they're coming down, but they're not really a risk of a true low blood sugar. The best treatment for prediabetes is, in fact, healthy behaviors. Weight loss, diet, and exercise rather than medications. So I would advocate for that more so than anything else.
Mona, would you like to answer one of your questions?
Actually, I think, oops.
Yeah, you're good.
This one, yeah.
Okay, talking to you.
I think one of these questions, excuse me, one of these questions I think is for all of us, and it's, will there be any handouts on tonight's topics?
So will there be any handouts for tonight's topics? There will be, we don't have a handout for videos.
So if you're interested in learning about the some of the community programs that are available, still can't.
We can't hear you. Here,
Okay, so
we're gonna
Yeah,
remic.
let me just.
So if you, on your evaluation form, if you write your name down there, you'll get a contact email that you should be able to get the PowerPoint presentations. Okay.
And I also have, we have a list of some of the community programs that are available for MBSR. If anyone's interested, I didn't make a ton of copies. I got it from another department here, but I do have some copies if you'd really like that tonight. Other than that, I think really if you can Google mindfulness, and as I said earlier, really John Kabat-Zinn is a really good place to start. That will give you some solid, good information.
I'll just do a couple of quick questions. Do we need vitamins, multivitamins? If you eat, as I talked about tonight, you will get all the vitamins, micronutrients that you need. Why were bananas not included in your presentation? No reason. You do have to be careful with bananas. They tend to be a larger size fruit. So because of the larger size, they may contain more carbohydrate. And vegetarian substitute meat or soy products is an excellent source of vegetable, plant-based proteins.
That was good rapid fire, Jill. Okay. So I got a question. If the 3-month A1C is less than 7%, should there be a concern if the fasting blood sugar is 8 or 9? Or you know, kind of in that context. I think it's a great question. It's actually commonly seen. And the A1C is the most important parameter as it relates to complications of diabetes. So that's what's going to drive my decision about medication change and so forth. However, to improve the fasting blood sugar, that's often related to activities the evening before, whether that be too much snacking the evening before or not enough activity after dinner. So usually to improve the fasting blood sugar, I'll try and focus on some evening behavior changes, as opposed to medication changes, which are more likely to be based upon the A1C change.
Good. Mona, do you have any comments on behavior changes that might be applicable to in the snacking?
Well, we know that behavior change is definitely a challenge. So I think one of the things that we often talk about is to try to set small, achievable goals, to not try to do too much at once. So to think of something that you know that you can accomplish, that's doable for you, and that you want to do. That's really important.
Thank you.
Okay, I'll do another. You have a lot, okay. All right, so the question is, does being a statin mean you will get diabetes? That's a good question. Let me repeat it again. Does being on a statin, like Lipitor or Crestor, does that mean that you're going to get diabetes? So statin therapy has been associated with increasing the risk of diabetes. What that means is that if you have about 250 people given a statin, one extra person would get diabetes. However, amongst those 250 people, you would probably reduce the risk of heart attack or stroke in 10 of those people. So the thing is like this, statins should be used in the people who it's appropriate to be used for, and it should be avoided in people who don't need it. But anyone with diabetes over the age of 40 pretty much should be on a statin because it significantly reduces the risk of heart attack and stroke. Side effects be known and acknowledged. The risk of heart attack and stroke reduction with a statin drives its use, and that's why it's so important for people to be on statin therapy with diabetes.
Mona has. Jill.
That's okay,
Jill has a slide. Yeah.
What is the role of controlling diabetes in the amount of water we drink? There's no guidelines in terms of specifics about the amount of water, but as Dr. Gilbert talked about, particularly if you're on SGLT2s, you do want to stay well hydrated. The average number out there is 6 to 8 glasses of water a day, and I'm not sure if that is backed up by any amount of research. But and if they
If you have heart failure, however, then you may need less fluids.
Yes.
So you have to be careful in that.
And kidney issues too.
Yeah, in that subpopulation. So there may be reasons why the amount of fluid intake may be different than the average based upon the individual circumstances.
So we should be discussing this with our healthcare team?
Yeah, absolutely. Okay, Mona's next.
So I have a question. This is actually an excellent one. I have to multitask like crazy at work. How do I change this there are so many demands? I tell you, if I knew the answer to that, I would be on an island right now. But it's a wonderful question, and I don't mean to make light of it, but it is a challenge. And I think mindfulness does help, because when you do practice mindfulness, you're able to be more focused on each thing that you're doing when you're doing it. But if anyone else has something they can add to that, I'd be happy to hear.
I think it can be very challenging. Yeah.
So this question is about, I talked about the rainbow, is it a new way? I just thought I wanted to present a different way of looking at healthy eating. And we often look at foods in terms of carbohydrate, proteins, and fats, but I thought tonight I would introduce looking further at the food groups in terms of quality. But the question also is in looking at incorporating carbohydrates and carbohydrate counting. And the idea is you always want to incorporate portion control and moderate portions into healthy eating. So it's choosing healthy foods or healthy starch foods, but portion and carbohydrate counting always come into play.
Okay, so next question. So if I am a vegetarian, but 20 pounds overweight, non-smoker, non-drinker, what is my risk for diabetes? So that's a great question. So the answer is that the risk for diabetes is not based upon just your weight or what you eat or your activity. It's also based upon family history and genetics and ethnicity and a variety of other factors. And really what it comes down to is what are the risk factors that are modifiable or changeable versus those that are not. Now, you cannot change your age. Sorry, impossible. Okay, and you cannot change who your family is. Also impossible. And in most cases, you cannot change gender either. But having said that, the things that you can change are diet, exercise, smoking, mindfulness, and a lot of the things that we've talked about this evening. And that will help reduce the risk of diabetes. So this individual who's a vegetarian, good, non-drinker, non-smoker, good, but is overweight, is at a higher risk for diabetes by being overweight. Focus on continuing to improve diet and exercise. And that's probably the best advice possible to reduce the risk for diabetes.
What is my attraction behind what is behind my attraction to chocolate and pastry versus reaching for fruit or veggie to give me pleasure? And how do I change this impulse? Again, an excellent question. Much of it is learned behavior. We're taught from a very young age that chocolate and sweets and pastries make us feel good. They also have a high fat content, and fat in food has a great texture and is very soothing. And certainly Mona's talk on mindfulness would be a way to work at changing this, to become more aware of the food choices and what you choose and how you're feeling, and trying to choose the fruit and vegetable option and learning the pleasure in eating those fruits and vegetables versus the sweets.
So I was asked about the connection between diabetes and Alzheimer's. It's an interesting question. So diabetes and Alzheimer's, the connection is controversial. So there's controversy regarding having very high blood sugars and predisposing to more dementia, maybe through vascular issues, and actually having frequent low blood sugars and increasing that risk. But the definition, the defined risk, the defined relationship between diabetes and Alzheimer's is ultimately unknown. And there is a lot of research currently being conducted. So you will hear about reports about this discussion, this topic. I think at this stage where it's too premature to give really a good understanding yet of that particular topic, but it's an intriguing area of research that's undergoing right now. She's okay.
Should people with diabetes be careful with sodium intake as well as sugar intake? Yes, because of the concern with heart health and blood pressure. So everybody should be eating lower sodium. But if you listen to much of my information about eating real foods, fruits and vegetables, and whole grains, those foods are not packaged processed foods, and naturally, none of those foods have high sodium contents, so it wouldn't be a concern.
Yeah, and just to add to that, the harm about salt as it relates to diabetes and blood pressure and complications is actually controversial. It was more clear-cut before, and it's kind of swung the pendulum the other way. So we're not really clear that salt is such a problem, except in heart failure. Person has heart failure, increasing salt intake is a problem. This next question was entitled Newest Insulin ? I'm not sure what that means. Suffice it to say the two newest insulins would be the Degludec insulin and Toujeo. And again, their advantage being smooth A1C, less hypoglycemia, and less variability is the ideal. And Fiasp would be the newest insulin in terms of rapid insulin, correct, which is a rapid bolus insulin.
Okay, so I'm going to power through these last few. Glycemic index, why no labeling on foods sold in Canada? Glycemic index really is just another tool or method to use when looking at making healthy food choices. So there's no labeling on it, because just because something has a low glycemic index in it doesn't necessarily make it a healthy food. Glycemic index only looks at the rate of breakdown of carbohydrates into glucose. So no labeling in Canada. I know it was originated between some researchers in Toronto actually and Australia. And I believe in Australia they do have the rating, but nowhere else in terms of glycemic index. It's just a tool. It's not necessarily the indication of nutritional quality. Here are a couple of other questions that I hope I can answer. Dr. Poon's diet limits fruits to 4 times a week. This contradicts what I said. Yes, because Dr. Poon is looking at a very restrictive intake of carbohydrates, and he's not necessarily looking at nutritional quality or nutrient deficiencies from what I am familiar with in terms of his dietary guidelines. Oh, can I comment on proposed sugar tax? I know that's come up in the US, looking at taxing foods that are, again, poor nutritional quality. It's not necessarily, and processed sugars. They're not talking about taxing foods that are natural sugars. Natural sugars are usually foods that are nutritionally dense and have good vitamins, minerals, and phytochemicals. So they wouldn't be looking at that. It's, again, those processed packaged goods, which nobody needs. In terms of tax, I don't know anything about the taxing now.
So I have,
Luna has a question.
Yeah, go ahead.
I have a question. What is the impact of technology on the brain and mindfulness? So that is another really good question. Can you hear me? You still can't hear me. Okay.
Can you give her that mic?
The question is, what is the impact of technology on the brain and mindfulness? So when we look at how scattered our minds are now, there's so much stimulation, people are reporting a lot more stress, agitation, anxiety. And this is an area that I think is really going to be a big area of research. Again, it's a great question, and I think that's why one of the suggestions that I made earlier was to try to take a break from technology. Something simple like even pick some times that you turn off your cell phone or your computer. Don't put your phone in your bedroom. Your cell phone, because that's actually interrupting your sleeping. And you don't get the same quality of sleep when you've got your cell phone in there. So I think it's something to really be cautious about, and I think we're going to be seeing a lot more research being done in this area.
So we have time for one more question. And then they'll be free to come up and talk to them. They're going to stick around for a bit.
So I think this question, I'm not going to read it out, is addressing sort of the cost of eating what I would consider to be real food, or fruits and vegetables and whole grains. And it doesn't necessarily have to be more expensive. There are lots of ways to get in a variety of different fruits and vegetables and whole grains in a reasonable cost, using frozen fruits and vegetables, buying in bulk your whole grains, cooking them from scratch, buying beans and lentils, very, very cost efficient and effective ways to make healthy eating. On the surface, packaged processed food often appears cheaper in the short term, but if you really look at in the long term, so it may cost you a little bit more sometimes up front, but it actually will last longer, and the nutrition quality of it is much, much better. So thank you.
Thanks, everybody, for coming.
We've come to the conclusion of our question and answer. Before we let you go tonight, just a few quick housekeeping items to mention. Recognizing the importance of learning from our patients, we have a blog called The Personal Health Navigator, written by former journalist Paul Taylor and published on our website. The blog provides advice to patients about hospital and their health care, relying heavily on medical and health experts. You can send your questions to askpaul@sunnybrook.ca. We hope that you've learned a great deal and found inspiring and motivation to care for yourself or someone you know. Hopefully, we provided useful information and support. A special thanks to all our speakers and those exhibiting outside the auditorium. Please be sure to hand in your completed evaluation form on your way out and pick up 3 free parking vouchers. If you'd like to join our mailing list, please write your contact information on the evaluation form for collection. The presenters will be available here at the front of the room for a few minutes if you'd like to ask any questions. Please visit the Sunnybrook website at www.sunnybrook.ca for updates. Thank you once again for joining us this evening.